Thank you everyone for joining. I'm really excited to be doing this webinar. As you know, we're going to be talking everything sex and cancer related. So we'll do a brief introduction of who I am, my research, what sex is, and then I've sort of split the presentation into 3 bits. So we're going to do some physical aspects, some relational changes, and then some interventions before I'll make a bit of a conclusion and then ready for the discussion. So my name's Sarah, and I have a bachelor's in psychology from the Netherlands. And then I also during COVID, became a sexuality educator. So that means I did focus on both children and adults, but I just personally really liked the education when it came to adults. I think that a lot of us have been failed by our education systems, sex ed systems. So I thought it was really interesting to go and see how to improve that. My own sort of approach with this is pleasure focused and sex positive sex education. So that just means that I believe it's more important to prioritize pleasure, fun, creativity, consent, and respect, rather than focusing on the horror stories and the cautions that we should all take. As important as they are, I think we're all having sex because we enjoy it. So I think that should be included in all sex education. I also believe that sex education should be lifelong. The interests, the knowledge that I need now is bound to change, and there is always more to learn. There is more that we find out within research, and there is always going to be things that are applicable to me at different life stages. And then after that, I am now in Rome doing my master's in clinical psychosexology, which is sort of a combination of the two I've done. So that's a very psychological, clinical approach to sexuality and sexual health, anything human sexual behaviors, really. So it can be anything from couples counseling and sex therapy to developmental traumas, fantasies, anything like this. It's a really interesting study, but I'm coming to the end. So I'm now finishing my thesis off, which is on cancer and sexual well-being, but I will explain more on that in a moment. I just think it's important first that we get on the same page about the word sex, because I'm of course going to say it a lot in the presentation, but I think it's really important to emphasize that sex is much more than penetration. I by no means only mean penetration when I say it. Some sexologists are trying to use different words, which I think is great. Esther Perel, if you know her, she uses eroticism a lot, or sexuality from Sexuality Educator is used to try and encompass the broad sense of what sex is, but I tend to just use the word sex. So I think it's important just to note that you get to define what sex is for you. And good tip is to make it something that you really enjoy. It doesn't have to be penetration. It can just be foreplay, masturbation, cuddles, massage, e-sex, like internet, any form of love or intimacy. It's really up to you to decide. The further that we move away from the idea of sex being penetration, the healthier all of our sex lives are going to get. So with that, my research is the mediating role of sex education on the sexual well-being of women dealing with either reproductive or non-reproductive cancer. A mouthful. What does that really mean? Well, cancer impacts sexual well-being. It's pretty well established, it's pretty well known. But sexual well-being, what is that? So the reason that I've picked well-being is because it's a really broad term. It's much more than function. It includes a subjective understanding. It's your cognitive and emotional subjective evaluation of your own sexual well-being. So it's yours. It can't be defined by a partner, by your doctor, by your physical function. Because I think within oncology, within a lot of chronic illnesses and pain illnesses as well, where function is impaired, it's really important to not assume that function means your sexual well-being is declined. There is many alternatives to have a really healthy sexual well-being when function isn't working at 100%. So that's why I've picked that. Why have I separated reproductive and non-reproductive? As I started this research journey, I was really overwhelmed by the fact that all of the research focuses on reproductive cancers. Of course, there's a really obvious link. When you think of testicular cancer, breast cancer, cervical cancer, you immediately think of sex and how that person's sex life has probably changed. But then the more recent research has also looked into non-reproductive cancers, and actually sexual well-being, general well-being, and quality of life decline at equal rates in both. But because of this research gap, there's not so much clinical opportunities available. Like, professionals aren't talking about it, oncologists aren't mentioning it to the non-reproductive side. They're not mentioning it enough within the reproductive cancers, but within non-reproductive, it's a real lack, and this is a real problem. So I wanted to sort of try and bridge that gap and try and create a research that's a bit more inclusive. I have focused on only women just because I had to narrow it down somewhere. And then I focused on sex education as a tool, hopefully. I will talk a bit more about why sex education, but what I'm hoping to find is that sex education can somehow protect our sexual well-being. After a cancer diagnosis, maybe it doesn't need to be impacted to the extreme that it is currently. Just got some notes down here. If I look down here, it's just to check that I've mentioned everything I need to. But moving on to the emotional understanding, I didn't want to give it a whole section because I think everything we're going to talk about, emotions come into it. Psycho-oncology, the study of emotions during cancer, is actually really well explored. It's very well funded, it's very well researched, and therefore it's pretty well understood. We know that cancer has emotional impacts, a lot of different ones. The big ones often shock, uncertainty, fear, depression, hopelessness, suicidal thoughts. But where this kind of stops is that we're not applying these emotions to how they're having an impact on sexuality, which is kind of surprising since we know that these emotions do have an impact on sexuality outside of the oncological setting. A lot of the time we understand that depression, for example, is linked to low desire, it's linked to arousal difficulties, and we know that treating depression can improve desire, can improve arousal difficulties, but for some reason we're not doing this when cancer's involved. The other one that comes up a lot is guilt. Guilt for wanting to have sex, guilt for feeling like I've been treated, I'm cured, why am I still complaining? You know, this shouldn't be a priority. Or for partners often having guilt for wanting to have sex with somebody who's had or has cancer. And the other one is a big one is self-esteem as well, that self-esteem is impacting a person's maybe drive to have sex. So somebody with low self-esteem after cancer isn't initiating intimacy, then their partner's interpreting this as not wanting it. So they're not initiating either. So then the person with the self-esteem is feeling like their fears of being confirmed, that they're no longer sexy. And then this is allowed to just spiral into negative relational repercussions, negative emotional and sexual repercussions, when it's not necessary. We know how we could stop this. But as we'll see, everything is very linked, everything is very tied together, and it's really important to sort of keep all of these different factors in mind to really understand the full picture. So the first section, the physical factors, too broad to mention everything, and I'm sure that there are experts here that know much more about the physical impacts of cancer than I do, but I'm just going to talk about the sexual ones specifically. So sexual function is defined as the absence of difficulty moving through the stages of sexual desire, arousal, and orgasm, as well as the subjective satisfaction with the frequency and outcome of sexual behaviors. So any deviation away from this is then defined as a sexual dysfunction. Overwhelmingly common after cancer is what I found. The research finds that more than 80% of people who have been diagnosed with cancer will suffer from a sexual dysfunction. And we know that from outside of cancer research that sexual dysfunctions are really emotionally distressing, can cause a lot of relational problems, a lot of self-image problems, but they are very, very rarely diagnosed and very rarely treated within cancer, which is an oversight and a letdown. Because it doesn't need to be like that. There is some research that's looked into it, and when sexual dysfunctions are correctly treated, it's a really positive outcome on general well-being and quality of life as well. So the most frequent sort of complaints and consequences include nerve damage. So nerve damage anywhere on the body, maybe from surgery or radiation, that could cause numbness and pain, which may make sex less appealing, may influence your desire. But specifically, if someone's had radiation or any kind of surgery in a reproductive area, that could also cause a dyspareunia, which is pain of the genitals, pain during sex. Or it may make arousal very difficult. It may make orgasm very difficult or not possible. Other things that influence arousal difficulty can be from hormones. If your hormones have been impacted, that may make lubrication more difficult within women, or erectile dysfunction can be very common after cancer treatments. And decreased desire. Desire is very complex, very emotionally linked too, but can also be impacted by the physical changes after cancer, surgery, radiations, the relationship changes. Is very broad, but it's important to acknowledge it because it's one of the most complained about factors after cancer. Then we've got the concept of sexual identity. This is defined as being a sexual being and being seen as a sexual being. So very, very complicated. It's very important for an individual to feel sexual. That is really integral to their sexual well-being. One of, I think, the most obvious factors that could influence sexual identity is the external disfigurement. This may influence your own body image, your own self-perception, but it may also impede on dating and intimacy. Then you've got mastectomies and hysterectomies. I will talk about them again, but emotionally very difficult, of course, but it also, the link here is that it can really impact a sense of woman, of a value of femininity or a value of womanhood that can really be changed after something like this. And that may change the value of what sex is, or your interest in sex, or being seen as a sexual person. Then you've got the relationship changes that come after this. So what I mean by this is that cancer can cause physical changes where a person may need some more physical care, and often their partner then takes on the role of being the carer. And this can really change the dynamic in the relationship. So instead of being two sexual beings that are intimate together, they take on this carer-patient role, which is not that sexy. So that can really put an issue in this of creating intimacy in the relationship. And then you've got the sexual patterns. And by this, I mean that, for example, if somebody has had a surgery where they now have maybe an ostomy bag, or they've had an amputation, this may change the physics of sex, how they physically can have sex. And that may mean that the relationship needs to navigate a new normal. Like I said, they may need to be a bit more creative with their definition of sex. Maybe it isn't just penetration anymore. The angles might be different. The positions that you try might be different. But if people aren't given that information, that can be a really big obstacle to overcome. And then I've got menopause. Just need to move the screen. So with menopause and infertility, this is one of the most troubling aspects of for women post-cancer, particularly younger women. Younger women are pushed into fertility decisions. Maybe they're in a relationship that isn't at a point where they're ready to discuss these decisions. Or it's also just an overwhelming barrage of decisions that you need to make. Do you want to have your eggs frozen? Do you want children? That can be really distressing, can change the value of sex, can change the thought of having sex, maybe it becomes less appealing. There's the concept of the returning of the period. So chemotherapy can often stop a period, and this is often said to be temporary, but that can also cause a lot of uncertainty. Waiting for a period, that's a lot of focus on your reproductive organs instead of just thinking of them as a place for pleasure and intimacy. And if your period does return, that doesn't assure you fertility. So that's also very difficult. Menopause has emotional impacts even when it occurs naturally. But when menopause is medically induced, we do know that the symptoms tend to be a bit more extreme, quite more severe in the fatigue, in bone loss, in cognitive dysfunction, and also in risk for some further complications like cardiovascular disease. So it's also a lot to deal with. The physical changes can be very heavy, and particularly for younger women, this can feel like a real out of time period. You know, their friends and peers may not be going through the same experiences and situations, so that can be a really lonely factor. But what we also know, which is what I mean with everything links back together again, is that menopause is also one of the biggest predictors for sexual dysfunction. So then we're back to this another one of the 80% that's going to suffer with a sexual dysfunction that causes more emotional turmoil, more relationships issues, and you will get that sense of how everything can exacerbate quite quickly. So then we've got the relational changes. Relationships are impacted by cancer. More than 80% say that there's an impact. Not always negative, of course, but the biggest, when researchers have asked this, the biggest complaints of what impacted their relationship was depression, anxiety, and sexual changes. There's very few opportunities for people to raise these concerns, though. So although the researchers are finding this, the individuals who take part tend to also say that they haven't had a space or a professional that asks them about this, maybe questions it, or just provides a moment to bring this up. And this means that they can often get out of control, and needlessly so, which is very common, more so for the partners of someone who's been diagnosed with cancer. They tend to have less face-to-face time with professionals, so they're having even less time to raise these points. And they also require support. They require education and a moment to unload and delve into themselves a little bit, which is also really important, they've found, for being a better support system at home. If the partner is able to have some kind of psychological help, they tend to then go home and be a better support for the person that's got cancer. Which is really crucial, because 23% of couples where one person's been diagnosed with cancer will separate. Don't panic, that's not that much higher than the general population, but this is 6 times more likely when the person who's diagnosed with cancer is the female in the relationship. So it is still a problem. It's needless in most cases, and it has a really severe consequence on the person with cancer's quality of life. Somebody who goes through a separation while they have cancer are less likely to take part in clinical trials. They're less likely to complete treatments, or they're more likely to be hospitalized, and single people are also more likely to have a cancer that metastasizes. So it's really crucial that we protect relationships. Of course, relationships may end, and that's no problem, but the ones that don't need to, there should be a support system for this, because having a healthy relationship can be really, really beneficial for the health and recovery of someone with cancer. It can improve their quality of life. It can improve their health trajectory, their participation in clinical trials, all these kinds of things. So it's really important that we sort of nurture the relationships that they're in and provide a space for both the patients and the partners to go and to air their concerns and to say that this is what's going on and maybe we need help, or we need to just check this is normal. Positive relationships are associated with much more positive body image. For example, there was research done in women who had breast cancer, and if they were, it was a heterosexual based research, and if they had a male partner at home who continued to touch their body and engage in sexuality, they were much more satisfied with their own body image. So that's really great for sexual well-being. There's also feelings of safety and social value, which can contribute to sexual well-being, because that's you need to feel safe. You need to feel that you have value in order to want to engage in sex. And the big one, I think, is maintaining normalcy. Sex will change. Lots of things will change, but if you can keep your sexual identity, keep feeling that sex is on the cards and that this is possible, then that can be really important for overall quality of life and the psychological adjustment to this huge change. So we know that relationships, all these things are important for quality of life, and we know that sex improves relationships. So we'd like to think there'd be lots of interventions. However, currently, there is nothing. There are a few if people go and search them out, maybe on some private health insurances, maybe through charities and online sex education, or if you go and seek out a sex therapist. But standardized in hospital, oncological, sexual well-being care is not common. And this is a real problem. So researchers are trying to fix this, and clinicians are also trying to fix this because people admit that that this is something that's lacking. So this is where we go back to the sex education. So this is one that I've honed in on because I personally think it's really important, and I think that it does hold a lot of value in oncological care. Sex education, we know, improves self-efficacy. This is a fact in any context, but what's important within oncology is that self-efficacy is the ability to act in a way to reach a goal. So it's the confidence to go and ask, to do the behavior, to go and improve your sexual well-being. So what this often means is that people who have had better sex education, usually the interventions where the research focuses on is sex education that has been given at the time of diagnosis or throughout the treatment process. Those people were more likely to go and approach their oncologists or other health professionals and say, this is happening. Is it normal? Is it okay? Do I need something? They were also more likely to approach a partner and say, I feel guilty. I do want to have sex, or I'm worried that we're not having sex enough, whatever their complaints may be. They're more likely to initiate those conversations. And that has a direct influence on their sexual satisfaction, on their marital adjustment, their frequency of sexual activity. It's a really important factor to building confidence to talk about sex. A lot of us aren't confident enough to talk about it, but when we're in a situation where we might need an extra bit of information or a helping hand, it's really important that we all have the confidence to reach out. Then secondly, sexual education is directly linked to a lower risk of sexual dysfunction. And as I discussed, that's really important. If we could lower the risk of sexual dysfunction, we can lower the emotional distress, we can reduce relational impacts and relational stresses, and we can overall improve quality of life. So if we give people more accurate sex ed information, they're given the tool to help themselves. It also alleviates guilt, it increases desire, arousal, orgasm, and satisfaction. And that is basically the definition of sexual function. So it really is, in my view, a really helpful and pretty simple way that we can improve sexual well-being for everybody. So yeah, something that we need to spend more time looking at. But in combination with this, we then also have couple support. So this is usually involves some kind of psychological support instead of purely informational. In these contexts, we need to focus on acknowledging the partners. It's brilliant to provide psychological support for the person diagnosed, but it's also crucial that we give the partners a space that they can unload, and I think also get everybody on the same page. There's a lot of research that suggests that the person with cancer and their partner have very different expectations on what sex should be post-cancer. What should sexual recovery look like, and what is the importance of sex? So if everybody could get a similar basis for their information on sex, and then the psychological tools in order to communicate this, in order to hear it and listen and understand, then the relationships can be a bit more protected, and we can maintain the quality of life better. And then we've got the professionals. I'm not sure if there are any oncology professionals here, but it's a problem. The professionals, oncologists admit that sexual health care needs to improve, but they also admit that they feel that they lack the knowledge and confidence to share this information. There's a lot of shame, a lot of embarrassment to bring up sex, to directly mention it. Particularly, a particular problem is when sexual side effects of treatments aren't mentioned beforehand, which should be a very standard part of informed consent, but it's awkward and it's embarrassing, so they tend not to. And then they're not sure maybe on how to ask, how to follow up, or even just how to answer the questions that are given to them. And importantly, this is even more difficult for when they're dealing with people who are LGBTQIA plus community who have cancer, if that's their patients. There is more focus on the fertility and menopause, which is great, but like I said, it's not the whole picture. So they need to do more. And I think that we can also advocate for more information and sort of try and build up a society with more confidence to talk about sex. As dreamland as that sounds, it would be great. So to come to a bit of a conclusion, it's a lot. There's so many different factors that link together, that influence each other. Everything works in feedback loops, and it's really important to maintain that image of the bigger picture, because there's no point focusing on one. We can treat the sexual dysfunctions, but if the relationship still needs support, if they still need psychological support, if the partner's still not being looked at after, then it's not gonna significantly contribute to quality of life care. Then we've got sex and relationships are important for quality of life. We know that. But when we're looking at this, we need to remember the partners. If we're going to come up with productive quality of life care, we've got to acknowledge sex, and we've got to acknowledge the value that it holds in everyone's lives. I believe this within everything, also outside of cancer. Sex is important. It does impact all of us, and we should talk about it more. And then we've also got the psychoeducation. So this is a tool that we need to acknowledge, and we need to embrace, and we need to use it. Even if there are no standardized interventions that are provided, I think it's important to continue to find accurate information, share accurate information, because we each have a right to pleasure. And it doesn't matter if you've been diagnosed with cancer or anything else. I think it's important to fight for your right to pleasure, because it will improve the future for everybody else as well. And then as well, the professionals need to do more. We need to advocate for the professionals to do more. We need to find space and work with each other, create interdisciplinary approaches where people, where patients feel that they can raise voice and say what their concerns are, what they would like, and where the professionals respond appropriately to this. That would be the dream. So thank you very, very much for listening. I am still in the active data collection phase of my research. Unfortunately, I am only looking at women, but if you have been diagnosed with cancer in the last 5 years and would like to participate, everything is anonymous. I'm looking at scores of sexual well-being and sex education. It's the QR code on the right. If you have not been diagnosed with cancer in the last 5 years and would like to participate, it's the QR code on the left. It's sort of a control group just to compare how cancer is impacting. Unfortunately, I also had to narrow down, and it's premenopausal women only, which is such a shame, and it's something I would really like to look into in the future. But if that applies, or if you know anyone, that would be really, really helpful. Thank you very much.